Hello everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. My name is Dr. Alex Spyropoulos, and I am Professor of Medicine at Hofstra Northwell School of Medicine, in addition to being System Director for Anticoagulation and Clinical Thrombosis Services at Northwell Health at Lenox Hill Hospital in New York City. I'm very pleased to be with you today and will be serving as today's moderator. Our topic today is a very important one within the sphere of venous thromboembolism, namely the topic is venous thromboembolism in children and young adults, state-of-the-art in diagnosis, treatment, and prevention. And we're very fortunate to have a true expert in the field presenting Dr. Neil Goldenberg. Now, before we get started, I'd like to go over a few housekeeping and poll points. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with a phone and access number as well as audio pin. All audio will be muted, and at the end of the presentation, there will be time for questions. To submit a written question for Dr. Goldenberg, please use the questions area of your toolbar. Dr. Goldenberg will respond to as many questions as time allows. Now, today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. We will begin today's webinar first with an audience poll. We are interested in knowing more about you. Please indicate your primary professional role. And if I can please have the first polling question. The question is, which of the following best describes you? Healthcare professional, pub health professional, researcher, industry partner, or consumer advocate? Okay, I think we've waited enough. Let's see what the answer is. Okay, we have a nice mix, but the vast majority of you all consider yourselves healthcare professionals. Excellent, excellent. So, without further ado, it's my pleasure to introduce our guest presenter, Dr. Neil Goldenberg. Dr. Goldenberg directs the Thrombosis Program and is the Director of Research at Johns Hopkins All Children's Hospital in lovely St. Petersburg, Florida. He also serves as Associate Professor of Pediatrics in the Division of Hematology at Johns Hopkins School of Medicine. Dr. Goldenberg leads the prospective multi-center evaluation of the duration of therapy for thrombosis in children, otherwise known as the KIDS DOT trial, that is funded by the National Heart, Lung, and Blood Institute and involves at this point more than 40 medical institutions. Now, Dr. Goldenberg is trained in both pediatrics and internal medicine and has a true passion for understanding thrombotic disorders in both children and young adults. So with that introduction, Dr. Goldenberg, and without further ado, let's please begin.
Thank you for that kind introduction, and welcome everyone. For the next 40 to 45 minutes, we'll be discussing the diagnosis and management of VTE in children and young adults. I'd like to review briefly an outline for today's talk. We're going to first have a discussion about the characterization and common parlance for describing VTE in young patients, and then move to an understanding of the incidence of VTE in young patients. We'll next move to discuss etiology and risk factors for VTE, and then proceed with a discussion of the management of VTE in young patients. Lastly, we'll take a look at long-term outcomes and prognostic factors in young patients with VTE and address some key unanswered questions in the field. By way of disclosure, I receive consultant fees from the academic research organization CPC Clinical Research for my work on steering committees and data and safety monitoring committees in pharma-funded clinical trials, and also for thought leadership in collaborative academia industry designs of new trials on behalf of the Atlas Group with CPC and worldwide clinical trials. I also receive research support through NHLBI for my role in the KidsDot trial.
Excuse me, Dr. Goldenberg. I apologize, but you're still on the title slide. If you could go up and make sure that you're not paused. There you go. Thank you.
Okay, thank you. In addition, by way of disclosure, it's important to note that this presentation contains references to off-label use of anticoagulants, specifically no anticoagulants that are used in the routine clinical care for VTE treatment in patients below age 18 years are FDA approved for the indication of VTE treatment. So let's start off by talking about the characterization of VTE and nomenclature. When describing VTE, whether in the literature or in clinical care, there are multiple categories that are important to reference. The first is anatomic site. In young patients, as in older patients, we see lower extremity and upper extremity DVT, and with regard to lower extremity DVT, these can be distal or more proximally can involve the femoral and iliac circulations. Similarly, in upper extremity DVT, these can be distal or can involve more proximal venous segments, including the axillary, subclavian, and brachiocephalic or innominate veins. Caval DVT is also important in young patients, particularly in the pediatric population, where it is not uncommon to have involvement of the inferior vena cava or superior vena cava with extremity DVTs. Pulmonary embolism is another important anatomic site. The pulmonary arterial vasculature can be involved proximally with main or lobar pulmonary arterial branches, or more distal involvement can include segmental or subsegmental branches, and the subsegmental involvement is becoming even more well-defined and prevalent through the use of highly sensitive diagnostic means such as spiral CT angiography. In young patients, we also see isolated internal jugular vein thrombosis, and perhaps more commonly we see IJ vein thrombosis along with cerebral sinovenous thrombosis presentations. And with regard to cerebral sinovenous thrombosis, there can be involvement of the superior sagittal sinus, the sigmoid or transverse sinus, the straight sinus, and some of the cortical veins as well. Renal vein thrombosis is particularly an issue in young patients. We see this in the neonatal population in particular. And as in older adults, splanchnic vein thrombosis is a concern involving portal vein or hepatic vein or mesenteric vein. Another categorization that is important to define is symptomatic versus asymptomatic thrombosis. Symptomatic thrombosis is that which is associated with signs or symptoms that are related to the site of deep vein thrombosis. For extremity or caval DVT, this can include painful limb swelling. With regard to PE, this can include pleuritic chest pain, dyspnea, or hemoptysis. Cerebral sinovenous thrombosis often presents with headache, with or without cranial nerve findings. And renal vein thrombosis classically presents with hypertension, hematuria, and thrombocytopenia, and can also have associated anemia. An additional classification that's important with regard to its therapeutic implications and risk for recurrent VTE, for example, is provoked versus unprovoked or spontaneous thrombosis. Provoked venous thromboembolism is that which is associated with an overt clinical risk factor, and in pediatrics we see greater than 90% of VTE are provoked. Common provoking factors are hospitalization, central venous catheterization, recent surgery or trauma, or the use of a prothrombotic medication such as estrogen-containing oral contraceptive pills, or in acute lymphoblastic leukemia patients, the use of L-asparaginase. Now, provoked versus unprovoked classification is not quite the same as idiopathic versus non-idiopathic, and this is seen sometimes in the literature and worth brief mention. So idiopathic venous thrombosis is that which is both not associated with an overt or disclosed clinical risk factor or a clinically significant thrombophilia. So truly no underlying risk factor has been disclosed on careful evaluation, including laboratory assessments. These idiopathic thromboses can be related to occult conditions. Non-idiopathic thrombosis can be related to occult conditions, and therefore careful evaluation in the setting of what is thought to be a spontaneous onset VTE is important in young patients. Sometimes we see the May-Thurner anomaly or venous thoracic outlet syndrome as an underlying occult cause on careful evaluation. In particular, in older adults, we see malignancy sometimes as the presenting feature for venous thromboembolism, although perhaps less commonly in younger patients. And anticoagulant deficiencies that are clinically significant can often be disclosed in spontaneous onset VTE in young patients, as we'll discuss a little bit later. So now let's move to an understanding of the incidence in young patients. And I think it's important to not look at pediatrics and young adults as a single entity, but to really have a perspective on particular subgroups by age in order to best appreciate incidence. So in pediatrics, we understand that there are bimodal peaks in the incidence of VTE, with peaks occurring in the neonatal period as well as in teens. And by comparison, from a similar data set of the National Hospital Discharge Survey, we see that in the young adult population, 18 to less than 40 years of age, the incidence is approximately 60 VTE per 100,000 patients per year, compared to in the adolescent age group a rate of approximately 10 per 100,000 per year, and similarly with infants. Now, the FIS data show an approximately 70% increase in the incidence of VTE from the years 2001 to 2007, and interestingly, this affects all pediatric age groups. Dr. Ruffini and colleagues published this in Pediatrics in 2009. And it's led to an appreciation that both our ability to recognize VTE as well as most likely the natural history of the disease are increasing. The VTE rate is approximately 8 per 1,000 admissions among neonates and teen from these FIS data. Let's now move to an understanding of the etiology and risk factors for VTE in young patients. As in older adults, it's very helpful to use a construct of the triad of Virchow when understanding etiology for VTE in young patients. This triad includes venous stasis, endothelial damage, and the hypercoagulable state. With regard to venous stasis, in young patients we see postoperative immobility and inflammation, casting or splinting of a limb, a sedentary state, and in patients with AML, leukostasis syndrome, and very commonly, particularly in pediatrics, we see dehydration as a contributing factor, which also likely contributes to the hypercoagulable state. With regard to endothelial damage in young patients, the use of central venous catheters is highly prevalent among young patients with VTE, particularly in the pediatric age range, and because most VTE in children occur in the setting of hospitalization, sepsis and trauma are also important comorbid conditions and risk factors. Antiphospholipid antibodies also, as we'll see subsequently, are thought to influence the endothelium adversely toward prothrombotic predisposition, as can hyperhomocystinemia and the use of certain chemotherapies or exposures to certain toxins. With regard to hypercoagulable state, as we'll discuss shortly, we have both inherited thrombophilia and acquired thrombophilia, which are both quite prevalent in young patients, particularly chronically ill children or those acutely hospitalized. Often have acquired thrombophilia in the setting of an inflammatory response. And also the presentation of VTE at a young age often is a selection for an inherited thrombophilia state. So now let's look at some of the Canadian Thrombophilia Registry experience published in 2000 in pediatric research by Paul Monagle and colleagues. We see that a central venous catheter is one of the most common underlying conditions in pediatric VTE, with malignancy or bone marrow transplantation also being a common underlying condition in that cohort of patients. Here I think the underlying conditions are going to be quite dependent on the cohort or registry of interest, but many registries and cohorts have also identified congenital heart disease as a very prevalent condition among VTE patients in pediatrics. Infection is in many other cohorts a very common superimposed condition as well. With regard to thrombophilia states, inherited anticoagulant deficiency appears to markedly increase VTE risk, and there have been meta-analysis publications of observational studies in pediatrics in particular that have shown that while these are rare in older adults with a first episode VTE, inherited anticoagulant deficiency is actually relatively common, a prevalence of approximately 2% among young VTE patients. And we're thinking about protein C deficiency here, protein S deficiency, antithrombin deficiency. What's also remarkable is that young VTE patients with inherited anticoagulant deficiencies appear to have an increased risk of recurrent VTE with odds ratios that vary between approximately 2.5 and 4-fold increase in risk. Population-based risk estimates from adult studies have demonstrated that heterozygosity for the factor II mutation confers an approximately 2-fold risk of incident VTE, and that heterozygous factor V Leiden confers approximately a 5-fold increased risk of incident VTE. I show here the risk that is associated with the use of the oral contraceptive pill because, as I show here now, its combination with factor V Leiden heterozygosity is synergistic with regard to VTE risk, such that patients taking OCP who have underlying heterozygous factor V Leiden are thought to have a VTE risk of 35-fold that of patients without either of those two risk factors. And that approaches the incident VTE risk increase among those with homozygous factor Leiden, which is 80-fold increase. Now, thrombophilia states, as I mentioned, in young patients are quite commonly acquired in nature. So we see increased factor VIII and von Willebrand factor in the setting of infection or inflammatory states. We see acquired anticoagulant deficiencies in sepsis and DIC, whether it's due to consumption in those situations or due to antiphospholipid antibodies interacting with the anticoagulate deficiency state. We also see activated protein C resistance due to exogenous estrogen use with regard to the oral contraceptive pill with the synergistic effect that was noted on the previous slide. Acquired antithrombin deficiency is seen in pediatric patients with nephrotic syndrome. It is seen in patients who receive L-asparaginase for ALL, and also in those who, following hematopoietic stem cell transplantation, suffer hepatic sinusoidal obstruction syndrome or veno-occlusive disease. We also see antiphospholipid antibodies directed against protein C or protein S in certain viral and bacterial infections causing a prothrombotic state. Now, the pathogenesis of antiphospholipid antibodies is quite complex and very interesting, and there are likely multiple mechanisms through which antiphospholipid antibodies can be pathogenic. this cartoon from Delat and colleagues from Blood in 2007 shows a model for disruption of the annexin shield on the endothelial surface, predisposing to thrombus formation on the endothelium. But APAs also likely work through endothelial cells, monocytes, and platelets to promote a thrombogenic state. Today there's a lot of interest in obesity, the epidemic of obesity in young patients in particular, and the question of whether this confers an increased risk of venous thromboembolism or could in any way be related to the observed increase in Vte incidence in pediatrics. Unfortunately, very few studies have been performed to date. I cite a few of them here. Halverson and colleagues this year in Hospital Pediatrics published their case control study consisting of 88 pediatric patients with VTE and 176 controls from the institution at Wake Forest and Brenner Children's. They matched on the presence of a central venous catheter and found that the BMI Z-score is independently associated with incident VTE, such that for each increase in Z-score by 1, there is a threefold increase in the odds of VTE. Stokes and colleagues at the University of Kentucky published in 2014 in Pediatric Hematology Oncology an additional case control study, this one consisting of 48 VTE cases and 274 controls under the age of 18, matched on age and gender, and found that a diagnosis of obesity was independently associated with incident VTE, such that the risk of VTE was doubled among obese children. So now we'll turn the page to management of VTE in young patients. And it's important to recognize that both clinically as well as in our clinical trials, the management of VTE with anticoagulants represents a balance between the risk of recurrent VTE that we'd like to reduce and the risk of serious bleeding that we would also like to keep minimal. Unfortunately, if this balance is not in the right direction, what we see is a predisposition toward bleeding while the VTE risk reduction is hopefully being achieved. This is a difficult balance, and the duration of anticoagulation is an important player in this balance so that we understand when the risk of recurrent VTE has sufficiently decreased to warrant removal of anticoagulation so as to not have an excess of bleeds in terms of net clinical benefit. So it's important to recognize that actually the evidence we have for anticoagulation in both older adult VTE as well as young adult VTE, including children, stems from early randomized controlled trials from the 1960s that involved adult patients with pulmonary embolism and/or proximal DVT, in which warfarin was compared to placebo, and warfarin was associated with a significant reduction in the risk of recurrent or progressive VTE, primarily PE events and VTE-related death. The FDA approvals for more recent anticoagulants and VTE treatment have been based on comparative efficacy and safety against either warfarin or low molecular weight heparins in general, and the efficacy measures have been recurrent VTE and VTE-related death, and the safety measures have been major or clinically relevant non-major bleeding in general. The American College of Chest Physicians 2012 guidelines give us a recommendation, mainly consensus-based with regard to pediatric evidence, on the management of pediatric VTE with conventional anticoagulation. And the adult guidelines are informed by greater quality and quantity of evidence for young adults and older adults. They share in common the concept that the initial or acute therapy in the first week conventionally has used unfractionated heparin or low molecular weight heparin, with subsequent subacute and extended period of therapy having historically relied on low molecular weight heparin or vitamin K antagonism. With regard to young adults, as part of the focus of this talk, we now have direct oral anticoagulants, whether to factor 10A or 2A thrombin inhibition that are alternatives to low molecular weight heparin and vitamin K antagonism for acute and subacute or extended VTE treatment. These include rivaroxaban, apixaban, dabigatran, and edoxaban for VTE treatment in the adult population. Now, with regard to the conventional anticoagulation in children, where I mentioned vitamin K antagonism, warfarin can be a challenge in pediatrics for a number of reasons, and there have been some investigations looking at what are the key determinants of variability in therapeutic warfarin dose among children. Leslie Mitchell and colleagues in 2012 published in Blood the findings of a German cohort that age is a key determinant of this variability in therapeutic warfarin dose per kilo among children, with some other important factors including warfarin dosing and adherence, as well as VCOR and CYP2C9 activity and vitamin K levels, with those factors being in turn influenced by polymorphisms as well as by concomitant medications and diet. But age was the key determinant in the pediatric population. There are, of course, alternative anticoagulants that I mentioned were conventionally and historically used. There are factor Xa inhibitors and direct thrombin inhibitors. Factor Xa inhibitors subcutaneously include fondaparinux and orally include rivaroxaban, apixaban, and edoxaban. The direct thrombin inhibitors include intravenously argatroban and bivalirudin, and orally include dabigatran. I have some helpful tips for pediatric VTE, which I think in the interest of time I'm not going to devote much attention to, but happy to address any of those in the Q&A portion of this session. I do, however, want to give some attention to thrombolytic therapy and the use of tissue plasminogen activator. The mechanism of action for TPA is different than the conventional anticoagulants, in that in this case we are actually talking about lysing thrombus through the activation of plasminogen to plasmin. The modes of administration for TPA in children and young adults include local bicatheter-directed infusion with or without mechanical thrombolysis, as has been used in limb DVT and unstable pulmonary embolism. But also systemically, TPA has been used with unstable PE and, for example, in neonatal bilateral renal vein thrombosis. Clinical scenarios where, as per the ACCP 2012 pediatric recommendations, TPA can be considered include acute limb or life-threatening deep vein thrombosis, acute PE with hemodynamic instability, and bilateral renal vein thrombosis. And the first two bullets are quite concordant also with adult guidelines. There's also an American Heart Association 2011 guideline that addresses the issue of occlusive iliofemoral DVT in young patients and suggests consideration of a thrombolytic approach in that patient population. Now, the NHLBI sponsored a track trial led by Suresh Vedantam, began in 2009 and is actually studying catheter-directed TPA versus conventional anticoagulation alone. In fact, catheter-directed TPA followed by anticoagulation versus conventional anticoagulation alone. And the goal is a 33% risk reduction in the risk of post-thrombotic syndrome, and we'll talk about PTS shortly. This trial began in 2009 and has a target of approximately 700 patients aged 16 to 75 years of age, so there is some broad representation of the adolescent and young adult population for VTE. I think it's very helpful to talk about special VTE syndromes that present particularly in young patients, adolescents and young adults in particular, and these include the May-Thurner anomaly as well as venous thoracic outlet syndrome. With regard to May-Thurner, the pathophysiology here is left iliac vein compression by the right iliac artery, and this presents as an unprovoked or minimally provoked left iliofemoral deep vein thrombosis. The management and natural history is such that with conventional anticoagulation alone, the risks of recurrent VTE and post-thrombotic syndrome appear to be high in May-Thurner, and there have been series that reported favorable outcomes with the use of pharmacomechanical thrombolysis with iliac stent placement, followed by a 3 to 6 month course of anticoagulation in general. Paget-Schroeder syndrome, or the venous thoracic outlet syndrome, is another special VTE syndrome presenting particularly in young patients. In this case, the subclavian vein is impinged by repetitive injury between the clavicle and the first rib, also involves hypertrophy of the subclavius and scalene musculature, and presents typically as an effort-induced unprovoked subclavian DVT in a young athlete. The management and natural history here, again, like May-Thurner, are ones of high risk for recurrent VTE and post-thrombotic syndrome with conventional anticoagulation. And here too, series and cohorts have suggested favorable outcomes with a pharmacomechanical approach, in this case followed by partial first ribectomy and debulking of the subclavius musculature, followed by anticoagulation for historically 6 months, and in the more recent literature generally 3 months. Here I show an image of Paget-Schroeder syndrome, where on the left-hand panel you see there is stenosis of the subclavian with little flow proximally, and then following thrombolysis, successful recanalization of the subclavian vein and blood flow. Now I'd like to turn to the long-term outcomes and prognostic factors in young-onset VTE. The long-term outcomes are different between children and adults with regard to recurrent VTE risk, and are rather similar from what we have as research evidence for post-thrombotic syndrome and generally from trials with regard to major bleeding. Adults have a risk of recurrent VT at 2 years of approximately 17%, and this appears to be lower in children. PTS appears to occur in approximately 1/4 to 1/3 of patients by 2 years follow-up, and major bleeding within the first 3 to 6 months of a conventional therapeutic period appears to be approximately 2% from adult trials. In children, we have fewer trials and more registry-based analyses with a highly variable rate, but appears to be approximately 2% for major bleeding. The post-thrombotic syndrome is another important long-term outcome that is gaining attention in the literature. And this is a syndrome of chronic venous insufficiency following DVT, whose signs include swelling, visibly dilated superficial collateral veins, venous stasis, dermatitis, and/or ulceration. In young patients, fortunately, most appear to manifest signs of swelling and dilated collateral veins without progression to dermatitis and ulceration. Symptoms can be quite variable, including pain and aching, heaviness, tightness, and are also age dependent in pediatrics with regard to the ability of a child to report the symptoms. With regard to predictors of outcome, work in adults has shown that elevated factor VIII and/or D-dimer levels after a 3-month course of anticoagulation are significantly more likely to develop recurrent VTE. And in children, we see that elevated factor VIII and/or D-dimer levels following a 3-month course of anticoagulation are significantly more likely to suffer a composite adverse thrombotic outcome that includes recurrent VTE, persistence of thrombosis following the treatment course, or the development of post-thrombotic syndrome. And the same appears to be true with regard to the factor VIII and D-dimer prognostic utility at diagnosis of VTE. Among adults with unprovoked VTE, an elevated D-dimer after discontinuing a 3 or greater month course of anticoagulation is also associated with a significantly increased risk of recurrent VTE, and this is mitigated by resuming anticoagulation. Now, there have been various predictive models for recurrent VTE, and I won't discuss them in detail, but these include the HER2, the Vienna prediction model, and the DASH score. And some of the factors across these models include gender, age, signs of post-thrombotic syndrome, BMI, D-dimer values, mostly after anticoagulation completed, but in the case of HER2 during anticoagulation. And this is a very helpful step in the effort to risk stratify patients with regard to recurrent VTE risk. Among children with unprovoked VTE, an interesting finding has been that the risk of recurrent VTE may be markedly increased among patients who have 2 or more inherited thrombophilia traits, and this finding was reported in Blood in 2001 by Ulrika Novak-Gödel. With regard to markers of inflammation, there are pilot data among adults that suggest that elevations in factor VIII activity, IL-6, or ICAM-1 may be associated with the risk of PTS and may increase that risk. When we focus on young adults, unfortunately very little is known regarding VTE outcomes in this population, and I may even venture to say that less may be known in this population than among children, where devoted studies have been performed and continue to be emphasized. Therefore, the prognostic factors in young adult VTE remain largely undefined. Unfortunately, meta-analyses that have been done in recent years that have been very informative to the adult population at large on major questions in VTE have not included specific subgroup analyses of the young adult VTE population. We see bleeding in the direct oral anticoagulants, mortality outcomes in direct oral anticoagulants, use of graduated compression stockings for PTS prevention, and the question of anticoagulation versus aspirin for extended VTE treatment are all excellent meta-analyses that unfortunately have not separated the young adult population. So I had the opportunity to discuss this with a colleague, Sam Schulman from McMaster, who was the author of the Durac randomized controlled trial that was published in New England Journal of Medicine in 1995 on the question of 6 weeks versus 6 months anticoagulant duration in adults. And as a credit to Dr. Schulman, he was able to provide some data as a preliminary post hoc analysis that looks at the young adult population as yet unpublished. And this shows that 10% of the study population was represented in the young adult age range, specifically 88 patients, 63% of whom were female. And the provoked VTE population was 63%, the remainder were unprovoked, and this shows a clear difference from pediatric VTE, where we have over 90% of patients being provoked in most studies. The risk of recurrent VTE in this study, I think, gives us a glimpse into what we need to study further in young adult VTE, which is 14% at 2 years in this population and 24% at 10 years. Interestingly, when one looks specifically at the young adults whose index VTE qualifying for the trial was a provoked event, the risk of recurrence at 10 years is 15%, whereas if one looks at the population who had an index VTE that was unprovoked, the risk of recurrence is 39% at 10 years, and this is concordant with what we understand about risk of recurrence for provoked versus unprovoked VTE across all age groups. Also very interesting was to see a low rate of major bleeding of 1% in this patient population of young adults from the Durac trial. So I want to finish with some key unanswered questions in young onset VTE. The risk stratification of VTE is really critical to inform risk stratified trials of VTE prevention in the future. And I think we're just starting to understand risk factors and risk models in the pediatric hospital-associated VTE population, where a lot of the thrombosis burden is occurring, and some concordant findings across various retrospective studies have been central venous catheter, length of stay, and ICU stay or mechanical ventilation as risk factors for hospital-associated VTE in children. Some of the risk assessment models that have been published include work from Brian Branchford and colleagues at Children's Hospital Colorado, Anjali Sharath Kumar, work from Riley Children's, and then 2 publications from Johns Hopkins All Children's. However, these models need to be expanded to multi-center models and also transition from a retrospective validation approach to a prospective validation approach, and there's an ongoing effort called the CHAT Registry led by Julie Jaffrey at CHLA, Brian Branchford in Colorado, and Arash Mahadran at CHOC and their colleagues. Another key unanswered question in young onset VTE is the safety, efficacy, and reversibility of the direct oral anticoagulants in the pediatric age range. There are multiple ongoing DOAC VTE trials in pediatrics. However, a look at clinicaltrials.gov finds that there is only one registered study, which is retrospective in nature and targets 10 patients, looking at reversibility in the DOAC VTE population among children, and this is idarucizumab in dabigatran-associated major bleeding. Another very important question in young onset VTE is duration of anticoagulation, as I mentioned with the DURAC study subset of young adults, but also in pediatrics where our current evidence really is extrapolated from the adult studies. The NHLBI-sponsored KidsDot trial looks at children with a first provoked VT episode from birth to 21 years of age and randomizes children to either 6 weeks or 3 months of the anticoagulant of choice following the ACCP guidelines for management, and looks at net clinical benefit. Getting back to the issue of that balance between bleeding and clotting, this is a simultaneous evaluation, or what's called a bivariate endpoint analysis, of symptomatic recurrent VTE on the one hand and major and clinically relevant non-major bleeds on the other, and uses the work by colleague John Kittleson from the Atlas group to model that analysis and interim monitoring. So there's a variety of resources, and one in particular that I want to mention for more information on pediatric VTE for patients, parents, and primary care providers, and that is the Stop the Clot website through the National Blood Clot Alliance. Has a web page on blood clots in children and resources, questions and answers, and also a downloadable PDF. So I encourage you to look there for further information. And I want to now turn it to question and answer and thank everyone for their participation in the webinar.
Dr. Goldenberg, we really thank you here for a truly state-of-the-art presentation in pediatric and young adult thrombosis. So again, our thanks for your terrific webinar presentation today. It was thorough and it was also on time. And again, just to remind our participants, please submit a written question for Dr. Goldenberg using the questions area of your toolbar. Now, we already have 2 questions, which I think probably will interplay with each other by one participant, which I think are very relevant to today's discussion, and both concern the direct oral anticoagulants. So I think we can generalize this question to all the DOACs, but the question in particular was for you, Dr. Goldenberg, do you use apixaban or other DOACs in 18 to 21-year-old patients? And how about their use in patients under the age of 18 years that are obese or greater than 50 kilograms?
Those are excellent questions and very commonly asked at many of our major meetings, and these are real challenges we now face in our young patient population. As I mentioned, warfarin can be a tremendous challenge with adherence and stability of therapeutic window in the young patient population, and so those patients that I have on long-term anticoagulation, when they reach 18 years of age, I do have a discussion of the risks and benefits of transitioning toward a DOAC for continued therapy, and also discuss the relative weight of the evidence on reversibility. I think one consideration is that we have a lot of published experience with warfarin with regard to what to do when we're encountering a serious bleeding episode, the use of fresh frozen plasma, vitamin K for most scenarios, and sometimes addition of FFP. And we have, as I mentioned, in the young patient population, relative paucity around evidence for safety and efficacy of reversal. So I have those careful discussions and have used the DOACs in the 18 to 21-year-old population and above. Under 18, my personal approach has been to engage in the ongoing clinical trials, but not to prescribe DOACs in the under 18 population for routine clinical care at this time as we await the efficacy and safety findings.
Thank you for that answer. And again, this is, as we both know, very common clinical scenario. The same discussant asked the question, because I know you mentioned a few ongoing prospective pediatric DOAC studies, but are you aware of any post hoc sub-analysis of the large phase 3 DOAC trials in young adults per se?
It's a very good question, and I'm not, and I think you know, our group and others are interested to start to address the young adult VTE population. I think our most modern sense of natural history is going to come through doing analyses across studies and across trials and focusing on that subpopulation, and I think it's a very exciting area that I'm very interested to explore. And so I hope that in the next several years we will have much stronger body of literature to inform the young adult VTE patient population.
Yeah, this is fertile ground for future research, isn't it? Okay, the questions are coming in hard and fast. So the other question concerns VTE risk stratification. You did mention some VTE risk models for primary prevention in hospital settings. What are your thoughts personally on VTE prophylaxis for children in particular in a hospitalized setting? Is there a particular resource or set of guidelines that you would recommend?
This is a very challenging area because this is a scenario where we have very little evidence to inform practice. What we have is clinical experience, and we have the emergence of some early findings of risk models, most of which are retrospective. So at the same time, we have the real problem of preventable death and preventable harm in children. And we have risk factor evidence that, albeit preliminary, I think rings true for many clinical experiences. So my personal approach has been to work with multidisciplinary committees at an institutional level to review the evidence and develop pragmatic EMR-based care pathway solutions that can be closely monitored with regard to prophylactic approaches, which include when to use mechanical prophylaxis and when to use chemoprophylaxis. I think there's not a one-size-fits-all approach. My personal approach is to look somewhat differently at patients who are in a critically ill setting than those who are non-critically ill, and medical patients differently from surgical patients. And I think that's that personal preference of mine and some of my colleagues at my institution is informed by a lot of the precedent in the adult literature for subgroup-based risk assessment and risk stratified preventive approaches. I think here we're going to learn a lot more as we have these multi-center collaborative risk score efforts and ultimately get to the point where we can understand the safety and efficacy of the interventions we wish to apply for mechanical as well as chemoprophylaxis in young patients.
And certainly, as you suggest, especially with the potential for a pediatric or young adult specific VTE weighted and scored assessment tool, we probably have to wait for prospective and multi-center validation, right, before we're ready to use it for prime time.
I agree. At the same time, I think on an institution-by-institution basis, many children's hospitals have decided to take a cautious step forward with some schema where they understand the very highest risk groups to apply some of these preventative measures and to closely monitor that while we get more robust research findings. And I think when those institutions choose to do so, they also build in careful evaluations for contraindications with the spirit of doing no harm as we try to prevent some of these VTE from occurring in the children in our hospitals.
Thank you. Yes. Now, actually going to a different vein, this is concerning adolescent females or young teens. So again, we have two questions, but very similar. In patients with established inherited risk factors or established thrombophilia, what type of birth control do you recommend, especially in the young teen population? Is an IUD or progesterone-only pill acceptable? Is there evidence for or against either? If you can expand on that.
Great question, and I believe we have had other speakers more expert than me on this topic, and will continue to do so in the field. I think rather than to answer what specific modalities I would recommend that are quote-unquote safe from the point of view of VTE risk, I would turn the question and say that I think that in my opinion, the best practice is collaborative management with gynecology program and colleague when it comes to the adolescent and young adult population. And I think there is no one solution for all patients. I think there are factors with regard to adherence as well as age of patient, lifestyle of patient. However, avoiding estrogen in a patient with a prior history of thrombosis, particularly if they have known factor V Leiden, APC resistance, or protein C deficiency, or in those with a strong family history of young onset VTE, I think is very prudent. As to what you use as an alternative, I think considering progesterone only is an option. Also considering in the appropriate patients, really as determined by gynecology colleagues, IUD with either local administration of estrogen or no chemo measures, I think can be appropriate choices.
Yeah, and as you stated, Dr. Goldenberg, I really like that pragmatic approach, but also team approach in emphasizing the role of gynecologists and other providers in this population, as that becomes important as well. Now, another question is, in the pediatric population, or even, let's say, young adult, are there data on compression stocking therapy? Does wearing compression stockings, specifically in the pediatric / young adult population, help with the post-thrombotic syndrome?
Yes, here the data are very limited, and I think it identifies an important area for analysis. This was obviously a contentious issue that was importantly studied in recent years in the adult population. For example, in the KidsDot trial, we will be looking at graduated compression stocking use and duration with regard to the PTS outcome that is a secondary outcome in the trial. So I think we'll have hopefully some very robust data in the future, but I think it's important that we continue to look at these in a number of studies. The issue of means to prevent PTS and whether GCS use is an important factor.
Thank you. I think, again, important that we keep focused on this for future research. Now, I think we have time for probably two questions, and I'd like to present this one because there is some controversy both in the adult world, but also I do think in the pediatric young adult world. And specifically, what are your thoughts about who you would or you would not screen for inherited thrombophilia in this population? I know there was a recent publication in the journal Thrombosis Hemostasis about data that suggests probably no routine screening for thrombophilia in central venous catheter-related thrombosis. But again, what would be your paradigm for screening for inherited thrombophilia in the pediatric young adult population?
This is a great question, and it's the subject of a lot of fervent debate. I think when you look at most of the published literature, there is not the demonstration of benefit, change in practice, or cost effectiveness of routine screening for thrombophilia in patients at risk. But I think it's important to take that a bit further and also to be precise about whether we're talking about screening or diagnosis. So I think in pediatric patients and young adult patients where there's a strong family history of young onset VTE, I think it's appropriate to talk with those individuals and strongly consider some evaluation for thrombophilias. And in my own practice, there have been innumerable instances where that has impacted my management with regard to episodic VTE prevention measures when those patients get hospitalized or have a significant risk factor. And as we just discussed, we don't have evidence for when to prophylax in the pediatric age range in particular. So informing that tough clinical decision, it can be very helpful to know whether a patient has thrombophilia. I think family history by itself may inform that even without testing. I think the subject of very heated debate is that of diagnostic testing at the time that a young patient presents with VTE. Should we be testing for thrombophilia, and if so, what should that assessment be comprised of? What I'm looking for when I assess thrombophilia is really a sense of risk for recurrent VTE. And so I'm focused on anticoagulant deficiencies, and if I test for genetic thrombophilias, I'm looking for homozygous states. There's a lot of practice variability on this. I don't think necessarily that an approach to do that testing is more correct than to not do that testing. However, I also look for antiphospholipid antibodies because the data are not clear yet in pediatrics, nor are they very clear in young adults with regard to whether or not antiphospholipid antibodies may increase the risk of VTE. But when I'm presenting to families and patients the difficult decision of whether we're going to treat for 3 months or 6 months or even shorter, I have to really disclose to the families and patients that we don't have evidence in pediatrics that is robust to inform that decision. So an individualized assessment of the patient's clinical risk factors, coupled by knowing whether or not they have an inherited anticoagulant deficiency that is associated with a higher risk of recurrent VTE, or a multi-trait thrombophilia that could be a harbinger for future recurrent VTE, I think is very helpful and informative until such time as we have robust data on duration of therapy. At that time, I think we'll reassess how much thrombophilia testing may help informing individual patient scenarios in pediatrics.
Yeah, thank you for that answer. Very, very thorough. This will be the last question, and again, this dovetails to your discussion antiphospholipid syndrome. Specifically, do you personally use DOACs and the pediatric young adult population with antiphospholipid antibody syndrome?
It's a great question. I have not specifically preferred one agent over another in the pediatric and young adult populations, and I think that's largely out of the sense that we don't have evidence to suggest we have superiority or inferiority of one agent versus another. I think this is another very important area, and with regard to the under 21 population, one of the secondary questions in the KIDS trial beyond the randomized question of duration of therapy is the question on an observational basis around whether pediatric patients with persistent antiphospholipid antibodies have an increased risk of recurrence and whether longer duration of treatment is better in those patients. So that will be a non-randomized comparison, but I think again offers the opportunity for very robust prospective multicenter data where then we can start looking at specific agents and durations in the APS population among the young.
Thank you, and I can't help but I'm going to have to also ask you this last question since we have the principal investigator of the KIDS trial. So there were a few questions on duration of anticoagulant therapy in seemingly provoked situations. So one question is, how long would you treat VTE in CVC or central venous catheter related thrombosis when the catheter has been removed? And another, I think, perhaps related question is, in patients with congenital heart disease who sustained a VT secondary to procedure such as cardiac catheterization, would you consider these provoked needing a 3-month duration versus longer? And of course, some of these questions may or may not be answered with the kids.dot trial, but I thought this was a good opportunity and an end opportunity for you to end on these questions.
Thank you. That's an excellent question, and I think that's a subject for almost an entire additional webinar, but I'll very quickly, perhaps overly generalize to say that my approach to CVC-related thrombosis, venous thrombosis, is that unless on a trial such as kids.dot, I use the approach of a 3-month course of therapy in those whose provoked risk factors have resolved or improved by the time of the 3-month therapy course. I think an understanding of what may be persisting chronic risk factors clinically and sometimes with regard to acquired thrombophilia is important and helpful. And I view the same for catheter-related venous thrombosis in congenital heart disease, although many of those are actually arterial, like femoral arterial. We do see femoral venous, iliac venous in congenital heart with relation to catheter procedures in the arteries. And here too, my approach has been anticoagulation for 3 months in the absence of an overriding factor that portends a high risk for recurrence. But I think here the question sometimes is, what do I do for secondary prophylaxis? Do we need to use an episodic prophylaxis approach for when those risk factors or new risk factors arise in those patients with chronic illness? And most of the CVC-related and cardiac cath-related scenarios we're talking about chronic illness where there may be more risk factors in the future.
Well, thank you for that concise answer. And unfortunately, I would like to go to the other questions, but our time is up. Again, Dr. Goldenberg, we thank you for really a terrific and very thorough webinar presentation today. I would also like to thank each and every one of you for joining us. We hope that this was extremely informative and clinically meaningful presentation. We would also like to thank our colleagues at the National Blood Clot Alliance for hosting this webinar. If you have any additional questions about today's presentation, please contact Cynthia Sayers at the address you see here in front of you, csayers@cdc.gov. This webinar will be archived, and the content will soon be available at the CDC's Division of Blood Disorders website that you can access. Please join us in the new year on February 16th when our next topic will be on the McMaster Guideline on Care Models for Hemophilia Management. And again, we thank you for joining us today and have a great rest of the day. Thank you.